Alrighty. I believe I should be recording, but welcome to my little overview of Tommy John surgery and UCL tear rehab. So first, let's start out with the anatomical location. So of course, we're looking more so at that medial aspect of the elbow right in here, and that is going to control the stability and resist valgus stress forces placed on the elbow, namely during throwing type and overhead movements. So this ligament has three bundles, the anterior, posterior, and transverse ligament. Your anterior bundle is going to be the strongest, as we have highlighted right in here, and is the culprit for instability and Tommy John surgeries. So that is going to be the part of the ligament that is going to get torn most frequently, as well as going to be repaired most frequently. Then we get into a little bit more of our functions. So transverse bundle also contributes to stability in the valgus loading, and can provide some structural support as it attaches to the anterior bundle. Posterior bundle is going to be more so a soft tissue stabilizer that is primarily used to stabilize during flexion. Mechanism of injury, you're going to be seeing a mechanism that is either traumatic and acute or is going to be more chronic in nature with overuse. So overuse is going to have the excessive micromotion at the elbow, leading to the microfractures in the elbow, as well as tears in the ligament. So micro tearing and fraying at the ligament, likely seeing more of a partial tear in that instance. And then excessive valgus stress, that's going to be our more so of our acute and traumatic onset during the late acceleration and cocking phase of the throwing motion. So coming through, we have our elbow cocked. We're going to have excessive elbow stress placed on it if our arm mechanics are going to be a little bit abnormal. Let's get into our risk factors and our signs and symptoms. So, risk factors, we have our baseball athletes, specifically pitchers, javelin athletes, quarterbacks, continual use, and micro traumas, previous injury and ligament laxity, which kind of goes along hand in hand with that micro trauma, as well as excessive valgus loading, and sometimes a Fuchs mechanism can do it if there is a little bit more of a higher force. Signs and symptoms. So, we have a couple of them that are big ones. Pain while throwing and loss of command while pitching and velocity decreases. Those are definitely going to be more sport specific. However, these could apply to anyone with reported mechanism of injury, as well as feeling a pop during a throwing/traumatic event. Pain immediately reported with ecchymosis and swelling in the medial elbow, as well as feeling like the elbow is loose or unstable. Then we get into our different severities. So grade one is our mild sprain. We're going to just have conservative management, likely are able to play through this and are just over the counter management. Grade two sprain and partial tear. This one gets a little bit gray because we're going to be able to need an MRI. We're definitely going to have some instability noted, as well as pain that's reproduced with valgus stress testing. They're unable to perform pitching or just overhead high velocity activities to the same level, but I would say likely are able to, with some strengthening and conservative management, we will likely be able to resume hitting at that, with this injury. Complete tear, we're definitely going to need to refer for surgical intervention if this patient is more so an art athlete. Could also have, if they want to continue on playing sports, is another way that we can look at it. Like if they want to continue their career in the long run, this is going to be beneficial for them to have. However, I know a couple people with complete tears that are just said that had it during sports, but were like, I'm not going to deal with it because I am finished with my career. So just being able to understand our patient goals can better understand if we're going to continue down that conservative management portion or we're going to refer out to our orthopedic surgeons. Differential diagnoses, muscular strains, especially the medial epicondyle musculature and flexor wad, posterior impingement of the elbow, medial epicondylalgia or golfer's elbow, and then neurological involvement. We could have like cervical radiculopathy, ulnar nerve traction, ulnar nerve entrapment with the ulnar nerve symptoms that we often notice during that mechanism of injury. Now, immobilization. Immobilization has been something that kind of comes under fire a little bit recently in some cases. However, with early management of this condition, it is necessary during the early portions of rehab. Now, immobilization, we need to use sparingly, but it also needs to be recommended, like to be able to have motion in it. So, for example, it used to be recommended that these patients would be in a plaster cast for a longer time. Now, research has indicated that immobilization should be used to protect, but it is vital that we are able to get some motion back in a structured manner to combat the effects of immobilization, such as weaker tissues in general. So it's kind of immobilization can kind of provide that reverse effect on our tissues as well. So prolonged immobilization, like I said, has been found to have profound negative effects and risks of re-injury on this population. Now, if we look at our post-operative protocol, this is going to definitely be our biggest takeaway from this little sheet that I have put together. Phase one, mobilization. Our goals are to relinquish effects of immobilization, decrease pain and inflammatory processes, decrease muscle atrophy. So now our interventions, a lot of range of motion stuff, a lot of initial post-surgical care, such as integumentary and scar care, grades 1 and 2 joint mobilizations, just to try and limit pain. We can progress in this phase to submaximal isometrics to prevent atrophy, get some grip strengthening so we're able to work both up the chain as well as down the chain into the hand, working on our hand intrinsics, as well as stabilization exercises of our scapulothoracic joint, which is going to be key in being able to resume throwing. Phase two, we're going to be looking to achieve full throwing range of motion, um, greater than 4 out of 5 strength of elbow flexors and extensors, minimal pain and tenderness, and so those are going to be our parameters for being able to progress into that stage. Next, we're going to be working on maintaining and enhancing upper extremity mobility, improving muscular strength and endurance, and increasing neuromuscular control of the elbow complex. This is where we're going to get into our more range of motion based exercises such as grade 3 to grade 4 mobilizations. And then we can also use a hinged elbow brace for controlled mobility and stability, as well as just gentle stretching of the elbow complex, because we're able to kind of produce a little bit of a creep effect as our tissues are modeling. So if I'm stuck here, eventually it's going to just come progressively and progressively out as we continue to adjust that brace. Now, we're also going to be really focused on overhead shoulder range of motion, as well as isotonics progressing from concentric to eccentric overhead motions, as well as making sure that we're facilitating forearm pronation and elbow extension flexibility for the return to sport. These are going to be key motions as we're coming up and finishing through. We're going to be pronating as well as extending at the elbow and bringing it through. Then for phase three, we're going to be working at our advanced strengthening phase. So goals are to increase strength, power, and endurance and neuromuscular control during high intensity events, such as throwing, because throwing a ball maximally is a very intense event at each joint that it affects, at the shoulder, at the elbow. There's a lot of force being put onto these tissues. Now, our progression criteria, we're going to be looking for full, non-painful external and internal shoulder range of motion, no pain and tenderness, and strength at about 70% of the uninvolved via handheld dynamometry. So we're able to quantify this a lot easier with that handheld dynamometry, which is why I added that part in. We want to be able to see that just compared to a manual muscle test, if we're saying, oh, this patient's at a 4 out of 5 compared to a 5 out of 5 on the other side, that's giving us an idea of where their strength is and that they still have some deficit, not necessarily what we're looking for in this case. Interventions, gradual progression to higher resistance, functional movements, eccentric contraction, and plyometric activities are going to be recommended. Elbow flexion exercises are also progressed to emphasize eccentric control, as we're going to be getting into eccentric elbow flexion to control the elbow's extension at the joint. Then lastly, we're going to have our phase four, which is our return to sport protocol. So this is going to be pretty general or pretty specific, I should say, not rather than general. It's going to be more specific based on what sport you are trying to return to. So you have different protocols for each sport. Now, in the resources that I've posted, I have linked to a lot of baseball type rehabs, but they can be translated to other athletes as well. Um, but our goals is full competition and interval throwing program as necessary. We want to be able to return to the full ability of the patient to get back out to playing their sport or performing their daily activities. Progression act criteria, again, we're going to be have to exhibit full pain-free throwing range of motion for an athlete or have no pain and tenderness, a satisfactory isokinetic test, and medical clearance or MD clinical examination. So that clinical examination by the doctor to say, all right, let's start. That's going to be needed before we are able to progress to this stage. Now, our interventions, return to throwing program, return to pitching program, return to tennis program, return to golf program, whatever that is going to entail, whether that's a systematic buildup as well as a systematic lengthening out of the like for a pitcher, we're going to see incremental progression. So from 60 to 90 feet, there's going to be specific things that they need to be able to acquire or certain velocities that they need to be able to meet that are going to be crucial to progressing them to the next stage. So being able to get more in depth on that would be something that I would be interested in looking at as well in a future video. Prognosis wise, full rehab can take anywhere from 12 to 24 months, depending on goals. According to multiple studies, the current prognosis is about 80 to 90% success rate. So that's pretty solid. Um, Very good for first timers, but you are at a higher risk to generally, um, you're at a higher risk with pitchers specifically as to having multiple. So, I mean, we've seen Cade Horton from the Cubs as a most recent example. He is now unfortunately having to undergo his second surgery in the span of 5 years. He had one at Oklahoma when he was a senior, I believe, or a junior, one of those two. But then now he just ruptured his UCL again, and he is going to seeing Dr. Keith Meister to have that procedure hypothetically. But yeah, so you are at a higher risk statistically of another tear if you have an initial. Then these rehab resources that I have posted. So I have multiple different resources posted on this page. We have Dr. Nikhil Verma, very well recognized elbow specialist from Midwest Ortho in Chicago. We have Massachusetts General, which generally has very, very good resources for progressions as well as, I guess, guidelines and rehab protocols. Then we have Parker Orthopedics, which is based out of Texas, which is another one that a lot of MLB players will go to. Um, TCO, also very well respected in terms of their work with the Minnesota Twins and Minnesota Vikings. And then again, I mentioned him before, but Dr. Keith Meister has been known to be a very, very productive and very well known elbow specialist for pitchers. And Cade Horton is being seen by him, I believe was saw by him this week as of recording this. But then I have my references down here. But yeah, thank you for listening.